Hello dear friends, how are you doing today? I hope you are doing well. We are going to talk about contact dermatitis. Definition: contact dermatitis is an inflammatory reaction of the skin precipitated by an exogenous chemical. The two types of contact dermatitis are irritant and allergic. Irritant contact dermatitis is produced by a substance that has a direct toxic effect on the skin. Allergic contact dermatitis triggers an immunologic reaction that causes tissue inflammation. Examples of irritants include acids, alkalis, solvents, and detergents. Innumerable chemicals cause allergic contact dermatitis, including metals, plants, medicines, cosmetics, and rubber compounds. Clinical appearance can range from acute or vesicles to chronic or lichenification eczematous reaction. Allergic contact dermatitis from poison ivy, linear red papules, and weeping vesicles is present in epidermis, vesicles, and spongiosis can seen, and in dermis perivascular inflammation is present. Incidence: contact dermatitis is a frequent problem that most people experience during their lifetime, whether it is irritant diaper dermatitis or allergic poison ivy or oak dermatitis. A significant cause of occupational illness, excluding injury, is caused by contact dermatitis, resulting in impairment and time lost from work. In occupational contact dermatitis, irritant is usually more common than in allergic etiology. History: one should first determine whether the contact dermatitis is an allergic or an irritant phenomenon. Skin damage is usually evident within several hours of contact with a strong irritant. Weak irritants, however, may require multiple applications days before the development of dermatitis. Allergic contact dermatitis usually appears 24 to 48 hours after exposure, before the development of clinical disease. Occasionally, the dermatitis may develop as soon as 8 to 12 hours after contact, or may be delayed as long as 4 to 7 days. The history of a precipitating contactant may be either obvious or obscure. Detailed history of occupation, hygienic habits, and hobbies is frequently necessary to find the contactant. Poison ivy or oak is a frequent cause of allergic contact dermatitis in the summer. The sensitizing allergens are pentadisylcatical and heptadisylcatical chemicals located in the sap or ursul of the plant. Another familiar member of this family of poisonous plants is poison sumac. Less frequently recognized family members are cashew, mango, and lacquer trees. Sensitization to poison ivy results in sensitivity to the other poisonous plants in this family. The characteristic eruption resulting from contact with poison ivy or oak is manifested by linear streaks of papules and vesicles, along with cellulating appearing plaques and patches. Contact with the smoke or burning plants can result in confluent severe dermatitis of the exposed skin. Cosmetics or personal care products contain fragrances and preservatives that cause allergic contact dermatitis, particularly affecting the faces of those who frequently use makeup and moisturizers. Paraphenyldiamine or PPD is a dye found in permanent hair coloring. Sensitization to PPD occurs in hairdressers and in clients who have their hair colored. Sometimes present in henna tattoos, PPD has caused severe blistering eruptions. When completely oxidized, as in the dye on a fur coat, PPD is not allergenic. In this photo, we can see poison ivy plant with characteristic 3 leaves. Note: streaks of vesicles are characteristic of contact dermatitis to poison ivy or oak. Nickel sensitivity is most often seen as a result of wearing cheap jewelry, commonly earrings. It is found in many metal alloys. One cannot be certain that the commonly advertised hypoallergenic earrings are nickel-free. Although stainless steel contains nickel, it is bound so tightly that it usually does not allow an allergic reaction to occur. Allergic contact dermatitis from nickel-containing snap and wash band, red scaling, and slightly crusted lichenified plaques can be seen. Rubber compounds are ubiquitous. Shoes and gloves are the most common sources of allergic contact dermatitis caused by these chemicals. An eczematous reaction limited to the feet or hands is typical of shoe and glove dermatitis, respectively. The most frequent rubber allergens are mercaptobenzodiazole and thiram. In sleuthing the causes of contact dermatitis, one must not overlook the possibility of a topical medication perpetuating or exacerbating a pre-existing dermatitis. Neomycin and bacitracin found in topical antibiotic preparations cause allergic contact dermatitis when these agents are used to treat cuts and abrasions, chronic ulcers, and surgical wounds. Physical examination. Contact dermatitis may be acute or chronic. The configuration of the lesions depends on the nature of the exposure, which may result in patches or plaques with angular corners, geometric outlines, and sharp margins. Poison ivy or oak characteristically causes linear streaks or papillary vesicles. The location of the dermatitis is helpful in predicting the causative irritant or allergen. The head and neck are frequent sites of contact dermatitis from fragrances and preservatives found in cosmetics. Hair dyes, permanent wave solutions, and shampoos produce dermatitis on the scalp. Eczema of the eyelids is caused by eye cosmetics or allergens that have been transferred from the hands, such as nail polish. Photoallergic contact dermatitis from sunscreens is produced by a photoreaction between sunlight and an allergen in exposed areas of the skin, such as the head, neck, V-shaped area of the chest, and arms. The hands are the most common area of contact dermatitis from industrial chemicals, particularly an irritant reaction from detergents, petroleum products, and solvents. Dermatitis of the feet is produced by allergens in shoes, such as rubber, chemicals, and leather tanning agents. The groin and buttocks in infants are frequently affected by diaper dermatitis. This condition is an irritant contact dermatitis from moisture and feces. Diaper dermatitis is often complicated by secondary infection with bacteria, and yes, note the location of the dermatitis often provides a clue to the nature of the contactant. Irritant contact dermatitis or diaper dermatitis, red patches can be seen. Differential diagnosis. Morphologically, contact dermatitis is identical to other eczematous eruptions and may complicate atopic or stasis dermatitis if the patient becomes sensitized to the topical preparation used to treat this dermatosis. Other causes of eczematous appearing dermatosis that may need to be ruled out include superficial fungal infections and bacterial cellulitis. In bacterial cellulitis, the skin is painful rather than pruritic, and the patient is often febrile. Note, for any dermatitis, ask, could it be contact dermatitis? The conclusion of differential diagnosis of contact dermatitis include any eczematous eruption, superficial fungal infection, and cellulitis. Laboratory and biopsy. No standard testing method is available for diagnosing irritant contact dermatitis. For allergic contact dermatitis, the causative agent can be identified by patch test, but this test must be properly performed and interpreted. Patch testing is done with a screening patch test series. This series is composed of medications, fragrances, preservatives, metals, rubber compounds, botanicals, and miscellaneous other chemicals. Individual chemicals and special trace, example, allergens found in plants, supplement the screening series. The chemicals are applied to patches that are taped on the back of the test subject. After 48 hours, the patches are removed and the test site is examined for an enzymatic reaction that is graded according to a standard interpretation key. A+1 reaction indicates palpable erythema, A+2 reaction indicates papules and vesicles, and A+3 reaction indicates bulla. A further delayed reading 1 to 2 days after patch removal is mandatory. Although the patch testing procedure is simple, its interpretation is often difficult. A positive patch test must be relevant to the eruption to be meaningful. Unknown chemicals and potential irritants must be patch tested cautiously and are best left to trained personnel who have experience in patch testing. Biopsy or contact dermatitis cannot differentiate between irritant and allergic causes. Contact dermatitis also cannot be differentiated histologically from other causes of eczematous eruptions such as atopic or seborrheic dermatitis. Positive patch test to paraphenyl endiamine. This was relevant to the hairdresser's hand dermatitis caused by permanent hair coloring. Therapy. Prevention of contact dermatitis is the most logical but often the most difficult solution. Avoidance of an irritant or allergen may require a change in lifestyle or occupation. Sometimes protective clothing is curative. Allergens that have a high sensitizing potential are best used in closed systems in which workers have virtually no contact with their offending chemicals. Protective or barrier creams are of questionable benefit. Sometimes the offending material can be substituted with another less toxic or allergenic chemical. Predictive testing for contact irritancy or sensitivity is a standard procedure before introducing new cosmetics or chemicals. Acute severe generalized contact dermatitis is treated with a short course of systemic steroids, 40 to 60 milligram prednisone daily for a minimum of 7 days, and then tapered away the next 7 to 14 days, or 1 milliliter triamcinolone suspension intramuscularly. Astringent dressings or soothing baths reduce weeping and itching. Mild dermatitis responds to topical steroids or to macrolide immunosuppressants like prototopic or Allergic. Systemic antihistamines such as 10 to 25 milligram hydroxyzine, 25 to 50 milligram diphenhydramine for 4 times daily, or cetirizine 10 milligram twice a day are helpful for pruritus. The conclusion of therapy for contact dermatitis include prevention like avoidance of irritant or allergens and protective clothing like gloves and so on. Initial therapy includes steroids, antihistamines, baths and compresses. Course and complications. Acute allergic contact dermatitis subsides within 3 to 4 weeks if the patient has repeated exposure to the contactant. Chronic dermatitis will develop. With the breakdown of the epidermal barrier, secondary bacterial infection may complicate contact dermatitis. Although contact dermatitis may start locally, generalized hypersensitivity of the skin can occur with resultant generalized dermatitis autosensitization. Pathogenesis. Irritant contact dermatitis is a non-specific inflammatory reaction resulting from toxic injury of the skin. Allergic contact dermatitis is a cell-mediated delayed type 4 immunologic reaction. It is divided into a sensitization phase and an Elicitation phase. The sensitization phase occurs when a chemical or hapten is applied to the skin of a non-sensitized individual. This chemical in itself is unable to induce an allergic reaction because of its small molecular size, which is usually less than 500 Dalton. It must combine with an epidermal protein thought to be on the surface of the Langerhans cell or epidermal macrophage. After the formation of the hapten protein complex, the Langerhans cells presents the allergen to T lymphocytes in the lymph node, where effector memory and suppressor lymphocytes are produced. The period of sensitization requires approximately 7 to 10 days. The elicitation phase occurs in sensitized individuals 1 to 2 days after exposure to the antigen. After presentation of the antigen by Langerhans cells to memory T cells in the skin, effector T cells produce lymphokines which recruit other inflammatory cells and produce allergic contact dermatitis. The dermatitis usually appears clinically 1 to 2 days after their elicitation exposure. The reaction is thought ultimately to be extinguished by suppressor T cells. Note, allergic contact dermatitis is a cell-mediated delayed type 4 immunologic reaction. Okay, this was an explanation about contact dermatitis. Thank you for your attention.